There are those times when you're just faced with this mountain of information, maybe really high-stakes stuff, and you just need to know, okay, what's the best way through this? How do we keep things safe when it's all so complex?
Yeah, that challenge is absolutely central to clinical risk management in mental health services. It's fundamental everywhere, but actually doing it well is, well, it's known to be pretty tough.
Right. Because there are so many factors, so much to juggle. And our source material for this deep dive,
Hmm.
it really flags some big issues with how things often work now.
Hmm.
Like, there isn't always a clear agreement on the best tools, or the best frameworks. And some key guidance, like the UK stuff the paper mentions, is from way back in 2009.
15 years. A lot changes in mental health care in that time.
Exactly. And the paper points out something else really critical. Sometimes there's this big gap between the formal risk assessments clinicians do and, the actual experience of the person using the service.
That's a huge point. It even highlights findings that the evidence actually supporting structured risk tools is pretty limited, even if practitioners themselves feel like they're helpful day to day.
That gap. Perception versus data.
Yeah.
That's interesting. So today we're diving into a recent perspective paper. It's from the International Journal of Mental Health Nursing.
Right. And this paper specifically talks about a project that was set up to tackle these problems head on. They aim to develop updated best practice principles for clinical risk management.
Okay, so our mission here is to unpack how they develop these principles and what they actually say.
Hmm.
We want to help you really grasp the nuances of modern clinical risk management in mental health, especially this really important shift towards being more collaborative, more person-centered.
Yeah, think of this as, cutting through all the complexity in the source material to get you straight to the core ideas.
Okay, let's get into it. First off, just to make sure we're all on the same page, what is clinical risk management in mental health and why is it such a big deal?
Okay, so at its heart, it's about focusing on potential dangers, dangers linked with mental health conditions. The paper mentions risk to self, that's things like self-harm, suicide, and risk to others, like aggression.
Right.
And then, after an assessment identifies potential risks, the focus shifts. You need interventions to manage or prevent those things happening, or at least reduce the chance they'll happen again.
And it seems like, historically anyway, a lot of the focus was on predicting risk, right? Trying to see the future almost.
Yes, that's been a major emphasis, and it's something the source paper really critiques quite strongly. It talks about this historical over-reliance on predictive approaches.
Which led to problems.
Sometimes, yeah, like problematic assumptions, maybe conflating a diagnosis. The paper uses schizophrenia as an example with an automatic assumption of higher violence risk, which the evidence doesn't really back up universally.
Or using those risk rating systems, the red, amber, green lights, or number scales.
Exactly. The paper notes those have sometimes been used purely for prediction, or even, and this is concerning, used to justify denying someone services because they got a high score.
Wow.
Yeah, and the paper is really clear on this. The evidence does not support using those kinds of ratings to reliably predict future harm or whether self-harm might happen again.
So prediction is out, but they might be useful for something else.
They can be, yes, for helping match the right interventions to what a person actually needs after you've done a proper assessment. It's about resource allocation, maybe, not prophecy.
Okay, so it's about how they're used, not necessarily the tools themselves being bad.
That's a really crucial distinction. And another thing the source points out is just the sheer lack of agreement, consistency in practice.
Like everyone doing their own thing.
Pretty much. They mention one study in UK hospitals found over 20 different tools just for assessing self-harm risk.
20 for just one type of risk. That
Yeah.
sounds fragmented.
It really highlights the need for better consistency, better training.
Yeah. And you mentioned earlier that disconnect with service users. That seems like a huge issue if we're aiming for care that's centered on the person.
It's a major theme in the source paper, definitely, and it's quite stark, actually. It says service users and their carers often aren't involved in the risk assessment process at all.
They might not even know it's happening.
Right. Or they might not be aware an assessment's been done, or they certainly aren't shown the results.
Why does the paper suggest this happens? Are there reasons given?
Well, the paper mentions factors cited in other research, things like clinical assumptions, maybe, that someone's mental illness means they're disoriented or they have risk illiteracies, like they can't understand their own safety needs.
Hmm.
And kind of worryingly, it also mentions the possibility of clinicians just not trusting what service users say about their intentions.
Which leads to.
More paternalistic practices, where the clinician basically decides what's best and the service user's own voice gets ignored or overridden.
Gosh, thinking about that from the service user's perspective,
Yeah.
how disempowering that must feel.
It really must. And that's why the shift the paper talks about is so vital, moving away from just focusing on risk to actively exploring and building safety and putting the service user right at the heart of that.
And that sounds much more aligned with, like, recovery principles, doesn't it?
Absolutely. Recovery is all about personal well-being, meaning in life, living fully, even with challenges. So this shift involves the person in figuring out their own safety needs, making sure plans actually support their life goals.
So it's not just stopping bad things, it's enabling good things too.
Exactly. Which brings in ideas like positive risk-taking or therapeutic risk-taking.
What does that mean in practice?
It's about agreeing collaboratively on certain calculated risks, guided by what the service user wants, maybe to improve their quality of life, or perhaps to use fewer restrictive practices like physical restraint in hospital, which the source notes can actually make distress worse.
That's a key point, realizing that our actions as clinicians can sometimes cause harm themselves.
It is, and part of this is also about psychological safety, making sure people feel safe to speak up, even when distressed, knowing they'll be respected, not, humiliated or shut down.
This all sounds way more dynamic, more individual than just using a static checklist.
It definitely is, and that's where formulation-based approaches come in. The source explains this move away from those static, predictive tools
Words.
towards building a shared understanding, a formulation. It's about figuring out together how, when, why risk events might happen for this specific person.
So weaving together the clinical knowledge with the person's own story, their history, their environment.
Exactly. It's like building a narrative. And formulation isn't just about spotting risk. It's also really important for identifying protective factors. What helps keep someone safe? What are their strengths?
Oh, no.
The paper mentions specific frameworks like WARN and FIRM as examples that have helped clinicians get better at this, improve communication, feel more confident using formulation for safety planning.
So instead of just a score, you're building a story with a person about their safety, their strengths.
That's a great way to put it. And absolutely fundamental to all of this is collaboration.
Right.
The source paper just hammers this home. Collaboration with service users, with carers, it's vital. It's central. It means clinicians need to be compassionate, work together, have really open communication.
Including about tricky things like confidentiality.
Yes, absolutely. Discussing the limits of confidentiality right up front. It's essential for building that trust needed for real collaboration. Ensures a person knows how their information might be shared.
Okay, so given all those challenges, the old guidance, the lack of consensus, that disconnect, how did this project actually develop these new principles? What was the process?
It was quite a unique approach, described in the paper as co-production, designed specifically to bring in different viewpoints. It was systematic, happened in 3 stages.
Okay, tell me about stage 1.
Stage 1 involved looking at that old 2009 guidance and all the relevant literature since then. And this review was done by 14 frontline staff nurses, allied health professionals, people using their practical day-to-day experience.
Right.
And that work led to the first draft, version 1 of the principles.
Okay, so starting with the folks on the ground, what was stage 2?
Stage 2 took that version 1 to a national group, 30 senior mental health nurses, leaders in practice, education, research, policy in the UK. They reviewed it online, gave expert feedback to refine it, make sure it fit with current thinking. That led to version 2.
Frontline, then national experts. And the final stage, stage 3.
Stage 3, and the paper really stresses how crucial this was, involved reviewing version 2 with 49 experts by experience.
People who've actually used mental health services themselves?
Exactly. People who have navigated the system firsthand. They gave feedback through online consultations, and that feedback led directly to the final version 3 principles.
Wow, bringing in that lived experience voice. That sounds incredibly valuable.
The paper says it was absolutely invaluable. Their feedback led to really important refinements. It strengthened the focus on really understanding personal needs, the absolute need for true collaboration, clearer communication, and building that shared understanding of risk and safety.
So the service users felt The final version really reflected their priorities.
That's what the paper suggests, yes. They felt it genuinely captured their needs. It really shows that commitment to being person-centered.
That's powerful. So the end result is these 10 principles. What are they meant for?
They're offered as a benchmark for practice, aiming to improve consistency, quality, and importantly, safety. And they stress, all 10 are equally important, no ranking.
Okay, let's unpack these 10 principles then. What do they actually say? How do they capture this new way of thinking?
Right, well, they really do bring together the shift we've been talking about. Principle 1, for instance, is the focus on safety, which means assessing both physical and psychosocial safety. Really listening empathetically to the person's experiences, their preferences, and working with their views to reduce harm.
Including harm from?
Not just harm to self or others, but also potential harm from others, or even harm that can come from clinical practice itself.
Ah, yes, that point again. The clinical actions can cause harm. It's significant.
It really is. Then principle 2 is about using a structured approach, but one that takes in diverse input. Meaning, clinical judgment should be structured, yes, but it has to be informed by the service user's own experience and history, input from family or carers if possible, training, evidence, and compassionate approaches. It's about pulling different kinds of knowledge together, not just a checklist.
And principle 3 acknowledges that risk isn't fixed, right?
Exactly. It highlights the dynamic nature of risk and how vital communication is. Risks change, sometimes fast. So you need teamwork, clear communication with everyone involved, and documentation that's flexible, that supports ongoing safety planning, not just a one-off snapshot.
Makes sense. Principle 4 focuses on safety planning.
Yeah, this says safety plans must build on the person's strengths and preferences. They need to identify protective factors, always use the least restrictive actions possible, and keep a clear therapeutic focus on helping the person live a fulfilling life. Keeps that recovery goal central.
And principle 5 just states it clearly. Collaboration is vital.
Yep. It underlines that assessment, formulation, safety planning, it must involve collaboration with service users and their family carers. Makes it non-negotiable for good practice.
Principle 6, then, is about clarity and trust.
That's the one. Clear explanation and confidentiality. It says processes, assessment, formulation, planning have to be explained really clearly in language the person understands. And crucially, talk about the limits of confidentiality right at the start so people know how their information is handled.
Principle 7 goes deeper into the goal of that collaboration, a meaningful, shared formulation.
Yes, this is key. Building that shared understanding of risk. Doing it in a way that respects cultural background, uses non-stigmatizing language, really reflects the person's unique experience accurately, and vitally is shared with them. It shouldn't just be a clinical note, it's a shared story.
Okay. Principle 8 gives that specific caution about stratification ratings.
Right, just reinforcing what we discussed. Ratings can help match interventions to needs, but they must not be used to predict harm, and absolutely must not be used to deny services.
Principle 9 then shifts the focus to the staff.
Yes, staff support and supervision. This highlights how essential regular clinical supervision and reflective practice are. It acknowledges the emotional effort involved. Supervision is needed to support staff, help prevent reliance on restrictive practices, and encourage therapeutic risk-taking.
And it mentioned something about the structure of supervision.
Yeah, the paper suggests ideally separating supportive educational supervision from managerial evaluation. Creates a safer space for staff to be open and reflect.
That makes a lot of sense. And finally, Principle 10.
That's about the whole service culture. Learning without blame.
So learning from things that go wrong,
Yeah.
involving service users and families, being open and honest, duty of candor.
Exactly. It frames this as essential. Fighting against a blame culture because that just leads to defensive practice, fear, and ultimately hinders good care and real learning.
Wow. Okay. Putting all 10 together, it really does paint a picture of a fundamental shift, doesn't it? Putting the individual, their safety, their voice, collaboration, right at the center.
That's certainly the goal. And while the project was mainly UK-focused, the paper argues these principles are relevant internationally. Places like Australia, Canada, the US.
Why is that?
Because they align well with existing international guidance that also emphasizes service user involvement, working together across agencies, person-centered care. It's a common direction of travel.
And these principles seem especially important for certain roles within mental health care.
They do. The paper stresses they're a benchmark for values-based practice. And since mental health nurses often lead on risk assessment and management, these principles are really key for them, promoting that relational approach, valuing dignity and voice.
And thinking back to Principle 9 about staff support, Given how much pressure and, frankly, anxiety can come with managing risk, that support feels absolutely crucial.
It's imperative. The paper is really strong on this. Regular, good quality supervision isn't a nice to have. It's essential for practitioners to do this work well and feel supported and safe themselves.
It strikes me these principles are trying to navigate something really tricky but important, that balance between sort of professional duty to protect and the service user's right to make their own choices, their autonomy.
That balance is absolutely critical, and the paper acknowledges different systems handle things like compulsory treatment differently, reflecting that tension. But the clear international trend, which these principles embody, is towards more service user involvement, more person-centered care.
Okay, so before we finish up, did the paper mention any limitations of this project or areas where more work is needed?
Yes, the authors are upfront about that. They note the UK focus, even though they believe it's relevant elsewhere. They also say that while the process was systematic and involved experts, it wasn't rigorous empirical research in the traditional sense. So there's potential for some bias.
And didn't they also mention it's hard to separate risk management from just good care?
Yes, that's another point. As practice moves towards safety being integrated everywhere, it gets harder to draw a neat line around risk management versus things like recovery-oriented care or trauma-informed practice. It all becomes interwoven.
So looking forward, what's needed next, according to the paper?
More outcome-based research, really, to see if these collaborative approaches actually lead to better safety outcomes, fewer adverse events. And they also call for more research specifically looking at the perspectives of service users and carers in all of this. Their voices are key.
Right. So to sum up our deep dive then, we've looked at how these updated principles for clinical risk management and mental health came about through this really interesting co-production process involving clinicians and, crucially, experts by experience.
And these principles really signal a major shift, focusing on building safety together, using individualized formulation, and creating a culture that's supportive and blame-free for everyone involved.
It really feels like this framework could be a big step towards a more humane, more respectful, and hopefully more effective way of supporting people through mental health distress and complex safety issues.
That's certainly the hope behind it.
And it leaves me thinking, with all the pressures in healthcare systems and maybe old habits being hard to break, how big is the challenge, really, to get these principles fully embedded into everyday practice? And what would care truly feel like for someone receiving it if these principles were consistently the norm? Something for you to maybe reflect on.